presentation is entitled Growing Beautiful Teeth. I'll just start out a little bit about myself and share my disclosures. My name is Nichole Skelton. I have a Bachelor's of Science specializing in dental hygiene from the University of Alberta. I am a member of the College of Registered Dental Hygienists of Alberta, the Canadian Dental Hygienist Association, and the International Association of Orofacial Myology, also known as the IAOM. One of the requirements as a member of the IAOM is to increase awareness about the issues I'll be addressing tonight to other health professionals and the public. I am not receiving any compensation for this presentation. It's intended to be 100% educational. I may refer to books, products, or services that I have found useful for myself and my clients, but I am in no way being sponsored or compensated by any company. Although I may refer to a specific brand, there may be others out there that are just as equal or possibly better. The information presented tonight is not intended as medical advice and should not replace the need for proper assessment or diagnosis by a dental or health professional. So the presentation tonight is based loosely on the book entitled Growing Beautiful Teeth. The presentation will be recorded, and a special thanks goes to Greenline Media. There will be occasional shots of the group, but it will be from behind, so there will be no faces in the video. Once the video is edited, I'm hoping to have it on my website so that people can refer back to it. I'll be going through a lot of the information very quickly, and some slides I've got quite a bit of information on there, and I'm not necessarily going to go through it all, and I'm hoping this can just serve as an opportunity as a reference to go back to. All right, so in summary for tonight, I'm going to be going through how to help make each tooth look great. That's kind of the dental hygiene side of me, and I'm going to go through that stuff pretty quick because I think some of it is a lot of stuff that people already know, but I think it's important to make sure that I go over it because it really does help to make a great smile. Then I'll be getting into actually what makes a great smile, addressing why people have crooked and crowded teeth, how to help prevent that, and to help with proper facial development. And then how these issues influence sleep, which can affect learning, behavior, and health, what things you need to look for in your own children, and then strategies to help. Okay, so making each tooth look its best. So the developing baby teeth begin early in utero, usually around 6 weeks. Almost 40% of baby teeth have some kind of enamel defect, which can affect the way the tooth looks or make it more susceptible to decay. 75% of these are believed to be caused by developmental issues. Common causes are infection or high fever when the mother is expecting, malnutrition, especially deficiencies in calcium, phosphorus, vitamin C, and vitamin D. Medication, in particular tetracycline is a bad one for making discolored teeth. Birth-related trauma, inherited diseases, and metabolic disorders. Right from birth, the adult teeth begin developing. So there are a lot of the same factors that go into what causes dental defects in adult teeth as the same as baby teeth. But one that is quite preventable is called fluorosis. So fluoride has been proven to strengthen the enamel layer and decrease the risk of developing cavities. Fluoride in community water is the perfect amount to help prevent decay. Higher concentrations on the enamel surface are beneficial, but should not be swallowed. If high concentrations of fluoride are ingested, it can cause a bad stomach ache, and it can also alter the way the enamel develops. If extremely high concentrations of fluoride are swallowed, it can be fatal. So fluoride is something that can have great benefits, but it can also be quite bad. So we just need to make sure that we're monitoring it carefully, especially in kids, and it's all about getting the concentration right. As babies' teeth start to fall out and the new permanent teeth start coming in, don't be shocked when you start seeing more yellow teeth. So that's totally natural. Permanent teeth are more yellow than baby teeth. I've put in a little bit about why that is there. If it's a major concern for people, there is whitening that you can do for children. It's usually recommended, though, to wait until all of the adult teeth have come in. Usually it's recommended about 14 to 16 years old for that. Teeth tend to get more yellow, though, as we get older. And the outer layer of the tooth is the enamel, and inside is the dentin and the pulp, and those are the living tissues. And as that gets older, it just naturally starts to become more yellow, and that shows through more. But we can get premature yellowing and discoloration from trauma, hard forces like grinding, and malnutrition. So what happens if a baby tooth falls out? Some takeaways are act quickly and get it back into the mouth as soon as you can. You don't want to let a tooth dry out. You also don't want to let it soak in regular water. You can give it a quick rinse if it's really dirty. Just touch it by the crown, never the root, and ideally get it right back into the socket as soon as you can.
I have a question. So
Yes.
That like a permanent, are you referring to a permanent tooth or like a baby tooth?
Oh no, if a child was to fall and the tooth actually came out and it has the whole crown and the root that's fallen out, you would want to get that back into the mouth as soon as you can, and ideally get to a dentist within about half an hour.
If it's a permanent tooth or if it's a baby either?
I guess it could be both. Yeah, if you want to get that baby tooth back in there, definitely get it back in there and see a dentist and see. If a baby tooth fell out, it's not as detrimental as if it was a permanent tooth. Yeah. So when should a child have their first dental visit? The Alberta Dental Association recommends from the time that their first tooth erupts, between then and their first birthday. So it's a good time to ask them about what fluoride recommendations they have for your child, which should always be based on the child's risk factor for developing a cavity. I also listed some of the ideas that the Alberta Dental Association recommended to make those first few dental appointments easier, and I've kind of listed those there. So home care, it's super important to be helping your kids at home take care of their teeth. So a lot of people think, oh, they're just baby teeth, they don't really matter, they're gonna fall out anyways. But number one, they act as a template for the next tooth. So I guess in answer, kind of going back to your question about if it was a baby tooth, it is important to have those baby teeth there because they do act as the template for the next tooth. Number two, if you have developed some bad home care habits with baby teeth, it's unlikely that when the adult ones start coming in, that all of a sudden you're going to be amazing at flossing and brushing your child's teeth. And number three, if the bacteria that's causing the cavities or gingivitis are in the mouth already now, when those adult teeth come out, that bacteria is still going to be there, and those new teeth are going to be more susceptible to having cavities and the gingivitis as well. So kind of going along with that, it's important not to share saliva with your baby. So it's good not to eat off the same spoon that you're going to be giving them. Don't taste it and then give some to them. It can transfer the bacteria that can cause cavities and gingivitis. So if you happen to have a cavity in your mouth and you taste it and then give some to your baby, it's passing that bacteria into their mouth, and it's making them at a higher risk of developing cavities or gingivitis. So the creation of a cavity. We have that bacteria that's growing on our teeth all the time. Then anytime you have anything that has sugar or carbohydrates, it uses that as food. And then as a byproduct, it creates acid. And if it continually has that acid on that tooth surface, it will eventually create a cavity. So every time you have something that has sugar or carbohydrates, an acid attack is created for 20 minutes. So let's say you have, or your child has a sip of apple juice, that's an acid attack for 20 minutes. If they take another sip a half an hour later, that's another 20-minute acid attack. So if you're going to give your child or yourself something that has sugar or carbohydrates, it's better to kind of clump that together, and then ideally even brush your teeth when you're done, But you don't want to prolong that throughout the day, or they're constantly being bathed in this acidic environment in their mouth. So xylitol, it tastes sweet like sugar, but it's different than sugar. It's converted in the mouth it's not converted in the mouth to acid and does not cause tooth decay. It actually reduces the level of decay-causing bacteria in your saliva. So you can buy gum or lozenges or mints or stuff like that that contains xylitol, and so it actually helps prevent cavities rather than contributing to it. Okay, so like I said, that bacteria is growing on your teeth all the time, and that's what plaque is, and that's kind of that upper left-hand picture there. And so it's kind of like a whitish, yellowy color. If you feel on your teeth should feel nice and smooth all the time, like a nice clean car. But if it feels kind of like sandpaper or fuzzy, that is plaque building up on your teeth. And that's what we want to make sure we're getting off all the time. And the problem with having plaque on your teeth is that, number one, it causes the gums to get inflamed, which then can cause the gums to become sore, causes them to bleed. The bacteria can actually get into your bloodstream, and it can cause other systemic problems. It's shown to increase cardiovascular problems, increase in stroke, in preterm babies, and in low birth weight babies as well. So we want to try and keep those plaque levels down. Wherever that plaque is, and it's having those acid attacks, if it's left on there, it is taking out kind of the minerals in that enamel surface. And so we get what's called demineralization. And so you can see in the bottom image those kind of white areas on those teeth kind of down along the gum line. And that's where the plaque had been sitting and causing demineralization. And so there's things we can do to help remineralize those areas, but the problem is that once you've had demineralization, it's left looking like that. So I remember showing a 14-year-old boy his bands of demineralization, and I'm like, I recommended a special toothpaste that he needed to start using to help remineralize those areas up. But I said, unfortunately, this is kind of how your teeth are going to look now. And I just saw him like kind of sink down. He's like, oh my goodness, I can't believe my teeth are going to look like this now, just because of not getting that plaque off. So we want to make sure we're really doing a good job of brushing our own teeth, but then also our kids' teeth. So we want to really be focusing up in a little space that's between the gum and the tooth. So there's actually a little pocket in between the gum and the tooth, and you don't really see it. But if you were to take a dental instrument and slide it down there, there's actually a space there. And bacteria likes to mainly start in any kind of little nooks and crannies or pits and grooves. And so on your biting surface where you've got those pits and grooves, it's really important to scrub those. But then you want to get up into that space. And the way I usually explain it to my dental hygiene patients is the bacteria is kind of like little links in a chain, and it creates this colonization. And then it puts a slime layer over top of that called the biofilm layer. And that is why when you're swishing around or eating food or drinking things, that plaque doesn't just kind of wash away. That biofilm helps to kind of act as a protective coating for the plaque. And it actually takes 5 to 10 mechanical motions to break through both the biofilm and the colonization. So when we're brushing, we want to be up in that area. We want to do 5 to 10 little vibrations, and then we want to kind of sweep it down. And for the backs of your front teeth, you want to put the brush straight up and down, and you want to be able to feel those very front bristles getting all the way into that space between the gum and the tooth. So here's kind of some images. If you have any questions, I'm sure your hygienist or dentist would be happy to help you there. Research has shown that electric brushes do a better job of removing that biofilm and the plaque. So it's recommended that you brush your teeth for 2 minutes, at least 2 times a day. 2 minutes of brushing with an electric brush equals about the equivalent of brushing with a manual brush for about 7 minutes. So it's substantially better. You don't have to get the most expensive toothbrush out there. I just picked one up at a Black Friday sale for $35, And then you could even have everyone in the house using the same electric toothbrush, but you can buy replacement ends, and they usually come with little colored bands so you can tell whose is whose. All right, flossing is extremely important. This is a cute little comic, but I had to say I wasn't super impressed on what it was portraying. So it makes it sound like the only time you need to floss is if there's food stuck in your teeth. And like I was just explaining, the most important thing is that we're getting in there to break up that colonization and the biofilm. And great if we're getting out the food as well, but we really need to break up that. And then their technique that they're using there for flossing, not so great. So here's some pictures of what not to do. Once you get it in there, I do love how in that very top left-hand picture, that's actually the motion that you want to have the floss going, but they have arrows going back and forth, which is not the motion you want to do. You want to be going straight up and down, and you want to really be curving around. I always tell my patients, imagine you're hugging that side of the tooth, oftentimes it's called C-shaped flossing because we're really curving around both sides. Sometimes patients will curve in the front, but not in the back, and then they actually can end up cutting their gums. So you just want to really make sure you're curving both ways. So I've tried to give some images there to help. Also, you want to make sure that you're using, when you're flossing, you're keeping a small amount between your fingers. If you get too far, you're not going to have good control. Another thing that can help, especially with kids, is if you tie the floss into a circle. That way they're not having to wrap it around their fingers and cutting off circulation. So that can be helpful. If I usually really try and work with patients to get them to figure it out, but I say if you've really tried for about a month and you still really can't get it, go ahead and try some other things. There's floss handles out there, there's floss picks. I really think that flossing with your fingers is the best because you can really do the curvature and get up into the pockets as best you can. For infants, when the teeth emerge, you want to gently rub the gums and the new teeth with a soft cloth and water after every feeding. It's all that you need to do. You don't need to use any toothpaste for babies. When the back teeth start erupting, you want to gradually introduce a small soft toothbrush. And I even have a picture here. You can even get some that can just go right onto your finger. It's good to just kind of run those under some warm water before you put it in, just to kind of soften it up a little bit. And then you want to be brushing at least twice a day. Before nap and bedtime are most important. So then once they're about 2 years old, you can start using kind of one of the little small brushes. And then you can start gradually introducing children's toothpaste. Now for kids up to 3, they actually say to just use the size of a grain of rice. So that's hardly anything. And unless your dentist has recommended that they be using fluoride toothpaste, it's best not to be using fluoride toothpaste until they can actually spit everything out. And so it's good when kids are little to start doing games with them, to start teaching them how to spit that out. And so that they can eventually get to the point where they can be spitting it out, and then you can start using fluoride toothpaste. I've put a bunch more information here, again, hoping you can refer back to this later. When you go into a store to get oral health supplies, it can be quite overwhelming. There's so many different options, and you're like, which one do I choose? So I just kind of wanted to hone in on, there are fluoride-free toothpaste out there, but you do have to really read the labels. So you can see here, fluoride-free toothpaste, but it should say on the labels whether it has fluoride or not. So for when kids are really little, before they're spitting everything out, again, good to use that fluoride-free, unless the dentist has recommended something different. Make brushing fun. Recent research shows it is important for parents to brush and floss their children's teeth at least once a day until they're 10 years old. This is really hard. It's very time consuming, and I have 4 children, so this is like the majority of my evenings, I feel like, is brushing and flossing my kids' teeth. And so but it is super important. So one thing you can do is to encourage them to do brushing and flossing in the morning, and then at night, mom or dad does brushing and flossing. And there's different ways you can do it if just to make it a little bit easier. I usually lie down, or not lie down, but I usually sit on one end of the couch, and then I have my kids lie down on the couch so their lap or their head is on my lap, and that's typically how I brush and floss their teeth. But there's a bunch of different ways here. Sometimes you actually need 2 adults to kind of help in that process, because kids can be uncooperative and it can be hard. But it is good to check and make sure that there's no underlying issues, that they might be having a fuss every single day. They can have kind of those webbed tissues that kind of is underneath the lip or on the cheeks. If those are super tight, it can actually hurt if a parent is trying to pull that away and they're trying to get a brush in there. So if they're crying every single night, you may want to take a deeper look. What's actually going on in there? Why are they saying it hurts, or they're really putting up a fuss? But gradually, if that's not an underlying issue, just keep at it, give positive reinforcement, try and make it fun. Okay, when should the teeth come in? For baby teeth, the average is about 6 months old. For adult teeth, the average is 6 years old. I've had a lot of moms say to me, my baby, their teeth just aren't coming in. And baby teeth actually erupt due to stimulation. And at 6 months, a really important stage starts with babies. It's called the oral exploration phase. And they need to be chewing on things. And they need to be putting things with different textures and flexibility into their mouth. And if they aren't doing that, they're not getting the stimulation that they need to help erupt the teeth. But it also helps in speech development. It also helps in other oral development with their proper chewing abilities and swallowing abilities. So it's a really important phase. If babies have a soother or a bottle in their mouth a lot, kind of 6 months up going, it's going to hinder that phase, because they're not getting that chewing and the variety that they need. So here's some products that are produced by a speech-language pathologist company, Art Therapeutics, and they have all sorts of different great products. You can get them through Amazon, but they are a little bit pricey. So if you really want to get some of those, awesome. They're great because you can stick it right onto those back molar areas, and they have all sorts of variety and texture, and they have firm ones, they have chewy ones. So those are really great. But again, if you don't want to spend the money, try and look for things that are comparable. Or you can even just clean your finger really well, or stick on a glove and have your baby chew on where their molars should be erupting, and that will also help the teeth to begin that eruption process. All right, so that was kind of my dental hygiene side. Now over to my orofacial myologist side. And this is where I really wanted to focus my time, because not a lot of people know this information. So the developing jaws and mouth are kind of like a lump of clay, and the sculptors are the muscles of the cheeks, lips, and tongue. And in the battle between muscle and bone, muscle will always win and the bone will be affected. So if we look at these facial profiles, which one do you kind of rank as most pleasing? And you'll notice their teeth aren't even showing. But when someone smiles, even without their teeth, there's people that we say, yeah, they've got a great smile. But a lot has to do with their facial profile as well. So I think most people would probably say that's kind of the profile. Now, obviously, genetics are going to play a big part in what our faces look like. But what helps the face develop to its full genetic potential is what the muscles are doing. And that is something that we can influence. So what your mouth is doing when you aren't doing anything is more important than you think. Just like when you put a child in braces, they're adding forces to the teeth to make it change. And the muscles are constantly acting on the mouth and face, even in the womb, like sculptors, to determine how the face and mouth will develop. So I'm going to be talking a lot about the palate. The palate is just another word for the roof of the mouth. So here was a dental hygiene patient I had. Now his teeth aren't 100% perfect. He fell on his front teeth when he was a child and now has crowns on those two front teeth. And he has a little bit of wear on his canines, but as soon as he opened his mouth, it's like, ah, he has a perfect, well, I shouldn't say perfect palate, but it's beautiful. It's low and it's broad and it's wide and it's given space for all those teeth to come in nice and straight. I want to compare this now to another dental hygiene patient I saw, and you can see the marked difference in the palate. So is genetics solely influencing how these palates developed? One of the biggest determining factors in how our smile looks is actually with what's going on with the palate and the jaws. So obviously not everyone is going to be on those extremes of kind of the perfect palate or like the crazy vaulted one, but we can still have a high vaulted palate and have it look differently. So this one on the left is kind of a high vaulted palate with more of a U shape. The one on the right is a vaulted palate with more of a V shape. Those are still not the ideal. And you can see with each of, well, especially the one on the left, you can see the crowded teeth. The one on the right, they've had braces and they have some wires in to help kind of hold that in place. So the tongue is actually supposed to be up on the palate. When it is all the way up there, it acts as a template for the upper jaw to grow wide and broad, which gives room for all the teeth to grow in nice and straight. So this is kind of what we want. We want the tongue all the way up on the palate. There are lots of forces going on in the mouth that act as those sculptors. So like I said, the tongue, the cheek, and the lips. So in order to have the teeth upright and straight, we need those forces to be balanced. In the back, you need your forces from your cheeks. In the front, you need forces from your lips. And from the inside, to balance that out, you need the force from your tongue. So that kind of, it all kind of balances each other out. And it shouldn't just be the very front of our tongue that's going up. It should be the whole thing suctioned up. So this image on the left has someone with just the very front part of their tongue going up to their palate. And this is what we don't want. The other thing that I don't like about this image here is that it's showing the tongue is right up against those teeth. We don't ever want the tongue touching our teeth. When you're swallowing, your tongue shouldn't touch your teeth. When you're just sitting watching a movie, your tongue shouldn't touch your teeth. When we're speaking, the only time really that it should be touching our teeth is when we make the TH sound. So those are kind of the only, that's pretty much the only time we want our tongue touching our teeth. And so this image over on the right-hand side, that's ideally what we want. We want the whole tongue coming up to palate. Okay. So if we don't have those balances with the forces, what tends to happen if that tongue is down low, now we still have that force coming in from the cheeks, but there's nothing there to balance that out. And so we end up getting a high or vaulted or both, high and vaulted palate. So our lips are meant to be our natural braces, and our tongue is meant to be our natural palatal expander. So I want you to just try for a minute, and I want you to give yourself a really good lip seal. So make your lips nice and tight. Now I just want you to slowly let that seal go and just let your lips just partly come apart. And I just want you to feel that little bit of that lack of pressure there. So it's not a lot of pressure, but research has shown that that little bit of pressure or lack of pressure over time is what makes a big difference in how our face and mouths develop. And this can actually start in utero. So previously, it was thought that excessive forces from, let's say, a tongue thrust, so someone who's always pushing their tongue really hard and forward, that is what causes a lot of orthodontic problems. But it's actually that just like constant pressure. And so someone who has a tongue thrust, most likely their tongue is always right there by the teeth. And so that is over time what's causing the problems. Now we're going to look at what else can happen when the palate develops high and narrow. So here's an X-ray. So it's kind of going like this. You can see the low tongue position down there. You can see the high arched palate. The roof of the mouth is also the floor of the nasal cavity. So when you have a high arched palate, now all of a sudden you've changed how your nasal cavity is developed. It is super narrow, and you only have so much space here. And so if it's high and narrow, all of a sudden the nasal cavity is narrow and small, and it's going to make it a lot more difficult for someone to be breathing through their nose. So this can also cause problems with nasal septum deviation. It also causes the sinuses to develop differently. So when the tongue is low, it can take up actually some of the space in your airway. When the tongue is up on your palate, it's up and out of the way. So research has shown that people who have restricted tongue mobility, which usually means that their tongue is not up on their palate, it's down low, it causes the palate to not expand to its potential. Maxillary hypoplasia is referring to that high, narrow palate. So the research has also showed that a low tongue position also causes soft palate elongation. So the narrow vaulted palate and an elongated soft palate are basically the perfect building blocks for sleep apnea. So people who don't have their tongue suctioned up to their palate are now at a higher risk for developing a variety of sleep disorders, which can ultimately lead to sleep apnea. Here's what a normal infant's palate looks like. It should be wide and low. And here we can see in the image on the right, the baby with their tongue up on their palate, and that's what we want. So again, back here to my 2 dental hygiene patients. So when I asked the patient with the nice, broad, and low palate about his tongue position, he said, oh yeah, my tongue's always on my palate, which is kind of crazy for me because that is not where my tongue ever was. I had a restriction, and I'll get more into that later, where my tongue was kind of tethered down. So it seems what you experience, you kind of assume everyone else has the same thing. So it just always blows my mind when people say, oh yeah, my tongue is always on my palate, because that's not how I was. And I almost didn't even need to ask this patient, because structurally, there is no way that his tongue could adequately suction to the top of his palate. And so I asked him about his ability to breathe through his nose, and he said, oh, it's so difficult. Like, I've hardly breathed through my nose my entire life. And it's been getting worse as I've been getting older. And it was something that he really wanted help with. I asked him if he had ever gone to an ear, nose, throat specialist, and he said he had. And I said, well, what did they say? And he said, they said, that's just how I am. And I just kind of have to deal with it, because this is just how my body is. And so, yeah, he's not happy about the changes that have happened in his mouth. Now, you can also see the difference, kind of. I mean, like I said, the first patient isn't 100% dental-wise, but you can see a lot of the issues that have kind of crept up with the patient on the right. He's got crowding. You cannot tell from this picture because I had used flash, but his gums and his palate were extremely inflamed. And when I was in there working, it was just gushing blood. Like, it was just, everything was so inflamed. You can see he's lost teeth, had lots of cavities. As we're breathing through our mouth, it increases the plaque that builds up. It also increases the bacteria that causes cavities. And it has less saliva to kind of counteract that and bring that back down. So we have all sorts of dental problems when people start breathing through their mouth. All right, so what causes the tongue to be down in the first place? So we need to look at the mouth as a system, kind of like gears in a clock. Everything plays a part to make it work properly. And if one of these get thrown off, it can affect the whole system. So there are usually 3 main underlying issues that can cause this system to go out of whack. So the first is airway issues or resistance or congestion. If you have a stuffy nose, you're not going to be able to be breathing through your nose. If your tonsils or adenoids are enlarged, or you've got allergies or nasal septum deviation, sinus issues, any of those, that's going to kind of stop that whole process from working properly. The next one is tethered oral tissues, commonly known as tongue tie. That's kind of what I was talking about with what I have experienced. And then the last one is noxious oral habits. So these can include things like soothers, bottles, sippy cups, thumb or finger sucking, what we eat, and even our habit of our overall posture plays a part in our oral system. So the first one, airway issues. So we can get enlarged tonsils, and the tonsils are the lymphoid tissue at the back of the mouth. They can be extremely small, like the picture on the left, or they can get extremely large and inflamed, like the image on the right. If they are taking 50% or more space at the back of the mouth, or they are asymmetric, so one's small but one's really big, you should probably have your child referred to an airway specialist or an ENT. Here's an image of enlarged adenoids. So same kind of thing as the tonsils, it's the lymphoid tissue, but this time the adenoids are at the back of the nose. So you can imagine if someone has extremely enlarged or inflamed adenoids, they're not going to be able to be breathing through their nose. And so this whole picture is actually not accurate because that tongue's going to be down and they're going to be breathing through their mouth. So here's an actual cross-sectional x-ray. So now we're looking at it this way of enlarged adenoids, and you can kind of see where it's pointed to there. And you can see how it's really restricting that airflow to the nose. So most likely this person is going to be breathing through their mouth. You can see the low tongue. You can see the elongation of the soft palate. You can see their lips slightly apart. You can see their tongue is touching their teeth. And you can see that that's actually having effect on the way that the teeth are developing. They're now kind of flaring outwards. And you can see there's the high palate. So allergies and congestion can also obviously cause problems and lead to mouth breathing. So here's an example of a physician's son when he was 10 years old. He had nice facial development going on. When he was 14, he was given a gerbil as a gift, and he kept this pet in his room. And unbeknownst to him, he was actually allergic. And so he began to get a stuffy nose and began to breathe through his mouth. And you can see the marked difference in the way the face developed. You've got the tired eyes, kind of the flaccid cheek muscles. There's not a lot of definition in his cheek muscles anymore. We have a short upper lip and a big kind of puffy bottom lip that looks quite dry and chapped. And you can see from the profile kind of the retruded lower jaw. So I want you just for a minute to actually now, we kind of did the slight lips apart, but now I want you to try opening your mouth a little bit wider and just see what you're feeling if you're breathing through your mouth. A couple things that you notice. So number one, if you were looking at me, it doesn't look that great. When someone's breathing through their mouth, it's not attractive. Number two, it dries out your mouth. That's kind of the first thing I notice. And then number three is the forces. And you probably weren't super aware of those, but you probably felt that downward force. But there's actually a slight backwards force as well when you're breathing through your mouth. And that's why we tend to get that retruded jawline. So it's down and then slightly back. So breathing through the mouth significantly changes the way the face and mouth will develop. And if that's a habitual thing that's going on all day, all night, it's really going to affect that. If it's something that's just maybe happening at night, we're still going to get some changes to the face. So the second thing is tethered oral tissues. So those are commonly known as tongue tie. They're sometimes called a lingual restriction or a tongue restriction, and medically it's known as ankyloglossia. So it's important to assess these by function and symptom, not necessarily by how they look. So if you were to go into a doctor or a dentist and ask to have your child or yourself looked at for a tongue tie, which I'll just add here tend to run in families, it tends to be genetic, and they proceed to ask for your child to just stick out their tongue or look underneath their tongue, those can definitely be part of what we'll look at when we're assessing for a restriction under the tongue, but alone these are not good assessment techniques. It is best to see someone who has been trained in properly assessing a tethered oral tissue. Most orofacial myologists should have training and education in this area, but I have learned that there's new stuff and research coming out all the time in this area, and so it's important for people who are looking at these things to always be up on what is current with the research. This last week I went and met with the doctors at the breastfeeding clinic, and they let me know that they also assess by function and symptoms for tongue tie before they do any clippings in the breastfeeding clinic, but only as it relates to breast or bottle feeding issues. So a child may actually have a tongue restriction, but it may not be causing any breastfeeding or bottle feeding problems. And so nothing is done about it when they're a baby. And so then it kind of continues on, and they think, oh, I don't have any tongue tie issues. But if they start having functional issues or symptoms that are indicative of a restriction, then they probably still need to get it released, even if it's later on in life. So like I said, if there is a tongue restriction and it's not caught at birth, it can cause a lot of issues for people as they get older. A lot of people that I see as adults in the dental hygiene chair, I'm always looking for these things. And so they tend to cause compensation issues. And so for a lot of adults, they will get frequent headaches, tension in their neck and shoulders, tension in their jaw, or then sleep issues. And this is a book I love. It's called Tongue Tied: How a Tiny String Under the Tongue Impacts Nursing, Speech, Feeding, and More. And so he is a pediatric dentist who was actually tongue-tied, and he didn't realize it fully until he had twin daughters who were both tongue-tied and not able to nurse. And so they started dealing with the issues that were coming because of that, and then he realized in himself that, oh, I've actually been tongue-tied. And he ended up having to have his tongue tie released multiple times because it wasn't getting done properly. It wasn't deep enough. And I think it was the third time that it was finally deep enough and he saw a resolution of all of his issues. So even if a baby gets a clipping or a tongue tie release done as a baby, it doesn't necessarily mean that it was deep enough, or sometimes it can reattach. So a lot of times people will say, yeah, I've got these issues, but I had that taken care of when I was a baby. And so there's no way it can be that now. And I said, well, you know, it can be that it wasn't deep enough or that it reattached.
Nichole,
Yes.
sorry. Would you go to a doctor to get it clipped, or would you go to a dentist?
I'm quite picky about who I trust in doing it because not everyone has had all the training. And so there's some people who will just do a clip on the very front. I kind of, actually in Dr. Baxter's book, he uses the analogy of syndactyly, so where a baby's fingers are fused together. But he said with tongue tie, it's the same thing, but it's kind of like the mucosa is covering part of that up. And so you may actually only be able to see that very end of it, and so a doctor might just clip the very end, but there actually might be more restriction deeper down. And so I kind of think of it as three different ways a frenectomy can be done. One is kind of that anterior clipping. One is a posterior tongue tie release where we see the nice diamond shape. That's really great. But there's also a deeper one that actually they open right up at the base of the tongue, and they actually will go in and release some of that myofascia tension. And so that's actually the one that I had done. And when I had it done, I felt a release of tension through my whole body. So really cool. I'm so glad I had it done. I had major tension all through my jaw, and I'd had splints, major grinder and clencher. And I was to the point where I could hardly eat breakfast some mornings. And I had splints, and sometimes they worked, sometimes they didn't. But now I'm 100%. Like, I have no pain. I don't grind and clench anymore. Yeah, so those, it's really great for. Who do I recommend? I have gotten Dr. Jim Olson at Chinook Oral Surgery to go down and get training for doing that deeper release, and so I work with him out of Chinook Oral Surgery. Yeah, so usually though he won't work on patients until they're about 8 years old because it is more invasive. So if it's before that and we're having issues, then we need to find someone else. And I'm working with some people who are, there's one dentist who has gone for training that I think is great training, but he hasn't gotten the laser yet. And then there's another dentist who has the laser who hasn't gone and done the training. That's on his to-do list, but I did just recently hear that there's another dentist in town doing frenectomies. But I don't know how, I'd like to actually see what they're doing before I would recommend anyone go see them. Okay, so habits. So I wanted to start with a good habit, breastfeeding. It's awesome. So we've known a long time that breast milk is best for baby, but we now know from research that it's also the best for developing a healthy mouth and face. Sorry, let me go back. I had more information here. Breastfeeding draws the nipple deep into the mouth and helps shape the palate. Breastfeeding requires the jaw to work and develop better facial muscles. Breast milk leads to better dental health. Oh, I keep going, sorry. I need to keep scrolling down for my information here. Studies have shown that breastfeeding prevents orthodontic problems, decreases the risk of developing poor habits, so it can be linked to thumb sucking or nail biting later on, and helps to develop the face properly. There are many reasons that women can't breastfeed, so I don't want anyone to feel bad. But if someone wants to breastfeed and they're having difficulties, it's important to rule out tethered oral tissues and airway issues prior to giving up on nursing. So bottle feeding. Bottle feeding uses different facial muscles and different amounts of pressure. Bottle nipples do not spread or shape the palate. Bottle feeding is more passive and doesn't require as much jaw compression. Oh, sorry, I keep messing up that. Multiple research articles that link bottle feeding with increased orthodontic problems later on. So if you are one of those parents who needs to use a bottle for your baby, there is a method of bottle feeding that attempts to mimic breastfeeding as best it can. It's called paced bottle feeding. So it's good to look up some YouTube videos to help with that. As I kind of mentioned earlier, at 6 months old, babies need to begin that oral exploration phase with chewing, putting things in with different textures, and a soother hinders that whole process. Some other reasons you want to get baby weaned off the soother by around 6 months is research shows that if baby is still sucking a soother at 10 months old, they have a higher risk of developing ear infections. It changes the swallow and promotes a more forward than upward pressure and contributes to developmental problems of the teeth and jaws. And if it is used often and long enough, it can hinder their speech progression. And the same kind of issues occur when someone is thumb or finger sucking. Traditionally in the dental field, if there is an ongoing problem with thumb sucking or finger sucking, they'll often recommend a cribs appliance, and there are a few disadvantages to this solution. Yes, it teaches the thumb to stay away, but it also teaches the tongue to stay away. That's the exact spot that we want the tongue. And here they're putting something in to teach it to stay away. Number two, it can cause stress for some children, and they actually decrease their speaking or eating and drinking. And there's some kids who have even gone into the hospital because They're just not getting enough food and water in them. It's not addressing the real problem that these children are sucking in the first place. And there's a variety of underlying factors that are linked to sucking habits. Some people have sucking habits that aren't a finger or a soother. Some common ones are their tongue, their cheek, hair, or other non-food items. Other noxious oral habits include nail biting, chewing on things like the end of pencils, or putting non-food objects into their mouth. And like I said, oral habits are often a symptom of another underlying problem. Sucking habits have also been correlated to airway obstruction and tongue restriction, or that tongue tie. And at the end, I actually have a handout over here on tips for helping to quit thumb sucking for children before the age of 5. So you can grab that on your way out if you need one. If you're still having difficulty after some of those tips, it is good to see an orofacial myologist. Usually at about 4 or 5 years old, they can start the program. We offer a habit elimination program, and the reason that these programs are successful is because they fully address the underlying issues behind the habit and the science behind the habit. And it works for children and teens and even adults who have tried everything else, because we're addressing all those underlying issues. Okay, sippy cups. The original sippy cup was created by an engineer who was just tired of their children's cups being spilled all the time. But no thought was put into how that affects the muscles of the mouth and how it changes the swallow and all those patterns in that oral system. So most sippy cups tend to delay or prevent the natural progression to a functional and mature swallowing pattern. Sippy cups with a valve are especially problematic because they encourage a tongue thrusting and suckling swallow. What we eat actually plays a part as well, or I should say what we chew. I'm not going to go into the nutritional side, but instead the consistency. How tough or soft are the foods that our kids are eating? Do they prefer to eat soft, highly processed foods like yogurt, pancakes, soft bread without the crust, pasta, fruits and veggies without peels, hamburgers and chicken nuggets? Or do they like eating raw carrots and celery, steak, tough nuts, and fibrous foods? It turns out that these food preferences make a big difference in the growth of the jaw and the facial bones. So there is research coming out from scientists who study skulls from history. And what they found is skulls from before the Industrial Revolution, particularly in where hunting and gathering were their main food sources. The researchers would rarely find high palates, narrow arches, and orthodontic problems. And you can kind of see the difference here in the hunters and gatherers versus more our modern industrialized diets. The difference in the palate size, the difference in, you can even see in the hunters and gatherers, they have all their teeth, including their wisdom teeth. And there was space for all of it to come in nice and straight. You can see the differences in their airways. So the airways from before were larger, and our airways now are smaller. And so again, here's some more differences that have been noted. I wanted to use this image because it shows you what happens when someone doesn't have adequate pressure on their jaws. So for example, someone who's lost all their teeth and they don't have that hard pressure that we get from chewing, it actually results in bone loss. So conversely, in a developing child, if the jaws do not receive adequate pressure from good biting forces, the alveolar bone will not grow and expand to its full potential. Bones, especially the bones in the upper and lower jaws, need pressure to grow. And there is a window of growth that this typically occurs. And so by the age of 7, over 95% of the growth in your intermolar width is complete. So that palatal, that size of your palate, it's pretty much done by the time a child is 7. And after that point, we can make changes, but it's just more difficult. And typically, even if we get the tongue in there, it's not going to be enough to fully expand that. If we can get the tongue in there before the age of 7, the palate is so malleable in those young kids that just getting the tongue in there can help to to widen that palate. And then posture. So this seems to be one of those issues that's a cyclical problem, where you aren't really sure which one came first. So research has shown that people who mouth breathe, in order to get a little bit opening up more in the airway, they'll move their head forward a bit. And research has shown that. But I know for myself, if I have my good oral posture, I've got my whole tongue up to palate, and I move my head really forward, I can feel the back of my tongue starting to go down. And especially if I move my head forward and down, this just really comes down and actually naturally wants to open up my lips too. And so if we start looking at things that are going on nowadays, technology really kind of sets us up for poor oral posture. It really, when we're looking down at devices, our tongue comes down, our lips tend to open up more naturally. You can see in 2 out of these 3 kids, their lips are apart, their tongues are down, and they very possibly are breathing through their mouth. So we want to get away from looking down at our tech devices. We want to try and having them right in front of us. So if you're reading your phone, I know it's kind of awkward and strange, but you want to try and bring it up so it's more at your eye level. And for every inch of forward head posture, it can increase the weight on the spine by an additional 10 pounds. So your head is actually about the weight of a bowling ball. And so if you imagine a bowling ball on top of a nice straight object, it kind of balances it there. But as that comes forward, that puts a lot of strain on those muscles back there. And you can end up causing all sorts of problems down the road. All right, other problems that airway issues, tethered oral tissues, and poor habits can cause. So a restricted tongue is associated with obstructive sleep apnea at a later age, and research shows that. So basically that means that if someone has tongue tie, it leads to sleep apnea. So what exactly is sleep apnea? The word apnea literally means without breath. So these include variations such as hypopnea, obstructive sleep apnea, and central sleep apnea. And these conditions cause serious health problems and can be fatal. So we often hear about sleep disordered breathing. So sleep disordered breathing covers both upper airway resistance syndrome. So that's when there's resistance up in the upper part of that airway, and obstructive sleep apnea, where the kind of tongue and the tissues are falling back and blocking off that airway. Both conditions are concerned with the passage of air or oxygen into the lungs, but they manifest in different symptoms and have different profiles and treatments. And this can include snoring. Sorry, let me just go back for just a second here. Okay, so mouth breathing is also an indication of upper airway obstruction. A child that snores and or mouth breathes in the night 4 nights of the week or more should be referred to a pediatric ENT specialist that has a special interest in upper airway obstruction. Someone can still snore even while they're breathing through their nose. So even if their lips are together, there still may be that resistance in the upper airway, and you can still hear that snoring even with the nose. Like I said earlier, a high narrow palate and elongated soft palate are perfect building blocks for sleep apnea. And now we have research showing that the high narrow palate is one of the signs for obstructive sleep apnea. So what are problems that can arise from having sleep disordered breathing? So sleep disordered breathing increases your risk of cardiovascular disease. Sleep disordered breathing increases your risk of cancer. Associations between upper airway obstruction, we see problems with behavioral problems, hearing problems, listening problems, memory problems, school performance, bedwetting, bloody noses, ADHD or ADD, poor body posture, high cholesterol, low blood oxygen levels, jaw and orthodontic problems, low energy levels, low iron levels, swallowing problems and food avoidance, sensitive gag reflex, high blood pressure, heart problems, visual problems, general body growth and development, people who have difficulty losing weight, and blood sugar regulation. So here's a patient checklist that Dr. McIntosh, a pediatric airway specialist and associate professor, uses to help identify potential airway problems for children. So he says, at night, does your child snore, have their mouth open, grind their teeth, sleep talk, experience night terrors, have bloody noses, toss and turn significantly, stop breathing, breathe heavily, sleepwalk, wet the bed, sweat excessively, drool, wake up through the night. During the day, are there concerns about concentration, school performance, outbursts of anger, excessive energy levels, hay fever or runny nose, choking on food, dark circles under their eyes, hearing loss, sinusitis, dry mouth, headaches, especially in the morning, behavior, emotional fragility, asthma, tired in the morning, tired during the day, avoiding solid foods like meat, speech problems, tonsillitis, bad breath, and a blocked nose. So those, if a whole bunch of those are kind of popping up, it's good to have your child or yourself see an ENT. I've also included a list of tongue-tie symptoms. I don't think I'm going to go through them all. You can use this as a reference, or I also have these listed on my website. Some of these are correlated solely with a tongue restriction, but some also have associations to sleep-disordered breathing because the two can go hand in hand. So tongue-tie is not the only thing that causes sleep-disordered breathing. So we need to make sure we're fully assessing all of these underlying issues. So it can be any of kind of these problems. And then the ones in blue are kind of some of the stuff that we can see from sleep-disordered breathing. So sleep, it's so important and it promotes optimal health. So for children 3 to 5 years old, ideally they should be getting 10 to 13 hours of sleep in a 24-hour period, which includes naps, and children 6 to 12 years of age, 9 to 12 hours of sleep. If they're not getting, they may be getting the quantity of sleep that they're supposed to be getting, but they may not be getting that quality of sleep. And so sleep-disordered breathing can cause behavior problems. It can cause problems that mimic ADD and ADHD. So if there's ever anyone who's looking into a diagnosis for ADD or ADHD, it's important that they've ruled this out first before they kind of possibly start going on the medication route. And then sleep-disordered breathing affects learning and academic performance. So here's a list of the most frequent symptoms found in children who breathe through their mouth at night. So difficulty listening, they often have chronic allergies, they might be fidgety during the day, might have restless sleep. If you're looking at their teeth, you might see some signs of grinding. They may be having focusing issues, and they might be wetting the bed. Or alternatively, they could just be getting up frequently to use the bathroom. It might not necessarily be wetting the bed. Stomach aches. So if their food isn't getting chewed properly, if you look at that top picture, there's some orthodontic problems going on there, and their molars aren't even touching. And so when they put food back there, they're not going to be grinding that down to the proper kind of pulp that we want it to before we start to swallow. And so that can cause constipation, which can cause abdominal pain. If they don't have a proper swallow pattern, they may be incorporating air into their swallow, and that also can cause stomach and abdominal pain. So what kind of things should you be looking for in your kids? So in the book, Dr. Dove kind of gives some great analogies, and I loved her book because it's very great for parents. It's just easy to understand. She uses great diagrams and things like that, and so that's why I kind of chose her book to kind of base my presentation on. But her first analogy is that she kind of compares the two arches to a foot and a shoe. So she said the foot is kind of like the lower jaw, and the shoe is kind of like the upper jaw. And sometimes they have problems fitting together. The second is a hat box analogy. So the lid, or the upper jaw, should just barely and slightly overlap the bottom lid, which is the lower jaw. So here we see an image. This is kind of what we want our teeth to look like. It should slightly overlap. Okay, so some problems that we can be looking for is, one thing you'll see is crowding. So if that upper jaw is too small and it's going down over top of the lower jaw, it's kind of like trying to put a too small of a lid on the hat box, and the bottom of the hat box kind of has to crinkle up or be crowded, kind of, you can see in her image there. And so we get lots of crowding issues on those bottom teeth. And then also that is associated with temporomandibular joint problems, usually later on. We can also get crossbite. So like I said, that we want that upper lid to be all the way going slightly over the bottom lid, but sometimes it's shifted, sometimes it's in on both sides in the back, and so that's called crossbite. Open bite. So that's usually something is in the way of their normal tooth eruption. So it could be the tongue, that the tongue is always up front and it causes the teeth not to be able to fully erupt around that. It might be a finger, or it might be the soother. We can also look for gummy smiles, and this correlates to low tongue posture. So if you're seeing kids who have a lot of gums showing, it's usually because the gums are growing in a downward growth rather than growing out. So the gums and the jaw needs to grow. And so in some people, it grows down rather than out. So I kind of had showed a picture like this, talking about their chewing. But this is a posterior open bite where they're open on those back teeth. And usually what causes this? The tongue. So it's down low, and the tongue is kind of overlapping and overflowing into that tooth area. And you can see actually on the bottom image, a really good, the bottom left image there. You can see the tongue kind of just billowing out onto the teeth. And so it makes it so the teeth aren't going to erupt fully. But you can see in the front teeth have over-erupted now. And another problem with that is that when the front teeth are over-erupting and we have those bottom teeth that haven't erupted as much, we usually will end up getting grinding going on. And so back to my picture with the kind of yellow teeth that we had the grinding, if you pay attention to what we're seeing, you can see the tongue down low and kind of sticking out on the sides. So grinding usually has a very strong correlation to a low tongue posture. Again, here's another image of grinding. So it kind of looks like someone's taken sandpaper to the tops of the teeth. And it might be in the front, but it might be in the back as well. And it's good to look at in your kids. You know, for my son, he was having sleep disordered breathing issues. And all of a sudden one day, it's like, oh my goodness, I can't believe I hadn't noticed, but his teeth were just kind of looked like someone had just taken a power sander to them. So that, it can also be, grinding is associated with sleep disordered breathing and sleep apnea issues. A deep bite. So when we want those teeth slightly going over top, but if they go significantly more, that is called a deep bite. And that can have correlations with frequent ear infections and jaw issues, so those TMJ issues in the future. Edge to edge, if you're seeing your kids like that, it usually means they're not getting enough upper jaw growth. And if you're seeing that and grinding, it's usually red flags for sleep disordered breathing. So with those cases especially, it's important to seek early intervention for upper jaw growth. And in underbite, or what we call an anterior crossbite, the upper jaw is even further back, and we have an increased risk for airway restriction and sleep disordered breathing. An underbite or edge to edge are one of those situations that we do see strong genetic influencing factors. But when research actually studied these individuals, they found that those with an underdeveloped upper jaw had a high occurrence of a low tongue posture. So there are things, even though this is very strongly a genetic trait, there are things that we can be doing about it. Overjet. So like we saw in that image of the x-ray with the enlarged adenoid x-ray, how the top teeth were being pushed forward, this is kind of what it looks like when you're looking at it, someone in their mouth. And that kind of goes hand in hand with excessive spacing. So their tongue is kind of in that low and forward posture. And the problem with that is then you end up getting what's called a lip trap. So their front teeth are way more forward than their bottom teeth, and the lip just nicely just kind of tucks in behind those back teeth. And the problem is that, like I said, forces are playing a part. And so if that's kind of what they're doing all the time, it actually perpetuates that problem and can make it worse. And then we have tethered oral tissue. So what to look for? There's different kinds. I'm not going to go through everything. But like I said, it's more about function and symptoms than it is really about the appearance. And then here's an image of a baby with a posterior tongue tie. It can cause breastfeeding problems and then problems later on. So if you happen to see white on a baby's tongue, it can be either thrush, but it can also mean that the baby's tongue isn't connecting with the palate and kind of wiping that milk off. So I've included some ways to kind of test to see if it's thrush or if it's actually just milk, and that can give you a clue that, oh, my baby's tongue is not contacting with the palate there. Another thing to look for is other tethered oral tissues. So the tongue is not the only restriction that you can get inside the mouth. So there could be a lip tie or a cheek tie. Some common problems with these is with nursing, babies sometimes can't flange their lips properly and they can't get a good suction if they've got a lip tie. It can also increase their risk of cavities. So I had chosen that image in particular because it shows some cavities starting on those front teeth. It just makes an area for the food or the milk to just kind of sit easier if there's that restriction there. And it also makes it hurt when you go to brush there. And so they tend to not do as good of a job with their brushing, or parents may not do as good of a job if it's hurting them. Lip and cheek tie can also affect a mature swallow pattern. As they get older, tethered oral tissues can be associated with some speech issues. Lip ties can also cause the teeth to come in with a gap, and a lot of the times it's not even noticeable until the adult teeth are coming in. But if we see either of these, a tight lip tie or tight cheek ties, almost always there is an associated tongue restriction of some kind. So it's good, even if these aren't causing functional problems, it's good for us to be looking underneath the tongue and seeing what's going on there. We also can be looking at the muscles. So looking at your child's facial muscles, do they have nice tone and development? Usually around the age of 4 to 5 is when a mature chewing pattern develops, and we should start to see some good tone. If they're still keeping those baby cheeks, it could indicate that they aren't moving on to a mature chewing and swallowing pattern. It can also correlate to an open mouth posture. So we can kind of see the differences. And especially this girl on the right, you can see the dark circles under her eyes, the flaccid cheek tone, and then her lips apart. As a result of these underlying issues, people can also develop what is referred to as long face syndrome. It refers to a facial appearance displaying a narrow or long face, usually associated with an open mouth breathing habit due to chronic nasal blockages and enlarged adenoids, which prevent the child from breathing through their nose. So it's good to look at what's happening with your child during their sleep. Are they breathing through their mouth? Are they breathing through their nose? This child on the left, it's the same child, but previously she had airway issues, and so this was kind of how she was sleeping at night. And you can see that kind of retruded jaw starting to happen. And then she ended up getting all of her airway issues treated, and she has started myofunctional therapy, and now she's breathing through her mouth at night. Another thing to look for is asymmetries. So there's actually been research to show that when there's tongue tie issues, it can cause asymmetries in the face and mouth, but also the whole body. You also want to just avoid things that can cause asymmetry. So if someone is always sitting kind of with their hand on their face in always the same position, it can actually cause asymmetry to the face. Or if they're sleeping on their stomach and it's putting pressure all night on their face, it can cause an asymmetry. Or if they're always sleeping on the same side. Also, if they're also chewing on the same side all the time, that can cause asymmetry. We want to hopefully try and avoid putting CPAP machines on kids because it actually retrudes the jaws, development of growing forward, because it's on there all night. And what we want to do is bring that forward. So if there are children who have sleep apnea and it's been recommended a CPAP machine, the most ideal thing to do is to have them get expansion, orthodontic expansion, and then also make sure they've seen an ENT, and then also to have myofunctional therapy to help open up all those airway issues. So the next thing to look at is the eyes. If you can see white under people's irises, it's a clue that they're not getting enough growth in their mid-face. Typically, they have flatter faces and often suffer from numerous symptoms of sleep-disordered breathing. If they have dark circles under their eyes, it's called allergic shiners, and it's usually a clue that they either have allergies, enlarged adenoids, nasal polyps, or sleep apnea. A downturned canthi, the eyes have kind of that droopy appearance. It can be a clue that the upper jaw has not grown correctly. So kind of a typical pattern for what we call orofacial myofunctional disorders is it starts with typically an airway obstruction or a tongue tie restriction. Then we get the lips opening for mouth breathing. The jaw is open to maximize that airway, or their oral movement is limited. The tongue position remains low, and it might be low and forward, or a tongue thrust, which is also called a reverse swallow pattern, is developing. Their hard palate narrows as their face grows. It causes occlusal changes, so that's orthodontic problems. It can cause speech distortions, and then eventually it can lead to sleep-disordered breathing, obstructive sleep apnea, or grinding and clenching. So we see a lot of these issues when people are adults, and we see them when their issues are on fire. At this point, it's not as easy to treat, and so it's important to start looking for the signs of the smoke and treating when these kids are much younger, because it's a lot easier to treat them when they're younger than waiting till they're getting older. And ideally, we're looking at it right from when they're born. So are they breathing through their nose, or are they breathing through their mouth? Another thing to look for is what's called primate space. So there should be a small gap between baby's teeth that's going to make sure that there's enough room for the adult teeth to come in. It might actually not have that space when the baby teeth first erupt, but as the jaw is supposed to be growing and developing during those first few years, by the time they reach about 5 years old, the jaw should have developed enough that now there are some gaps between those teeth. And if there's not, it can kind of be a sign that there's problems. So I found this picture, and even though when we initially are looking, we think, oh, it's a cute picture of a little girl. She's just lost her first tooth. But when I look at this, I see a whole heap of problems. So first of all, if she's probably 5 or 6 years old at this point, if she's losing her first tooth, and there's no primate space there. So I can already tell she hasn't had enough jaw growth. We can also see a possible restrictive lip tie. Now, whether that's functionally a problem or not doesn't really matter so much to me right now, but I would be looking at the tongue because they're usually linked. And from everything I'm seeing here, I don't know if you can tell in this image, but there's a tiny bit of reflection coming through that little empty space. I can see the tongue. It's down low. The upper jaw is showing vertical growth patterns growing down rather than a nice outward broad pattern of expansion. That further tells me that her tongue is always low, and it's not providing support for upper jaw growth. I see underdeveloped cheek tone. So if she's about 5 or 6, she should have developed a proper rotary mature chewing pattern at this point, and we should start to see some facial tone and definition in her cheeks, and I'm not seeing that. It's hard to tell from this image, but it looks like there might possibly be some darkness under her eyes. And if there is, that can possibly link us to allergies, to enlarged adenoids, nasal polyps, or sleep apnea. And I also see wear patterns. So I see that she's been grinding. So I need to dig a little deeper. Why is she grinding? So does she have sleep-disordered breathing? Does she have a low tongue posture that's causing an over-eruption of those front teeth? And is it possibly linked to a tongue tie? So my recommendations for her would then be a possible sleep study, depending on what the parents are observing when she's sleeping. An assessment to be seen by someone who is trained in all types of tethered oral tissues. If necessary, release any of those restrictions that are causing problems due to function and/or symptoms. Myofunctional therapy to get the tongue up and develop mature chewing and swallowing patterns. And depending on how narrow her palate is at this point, we may need to use some type of expansion device. Even if we get a sleep study done, sometimes it doesn't show, especially with kids, that they have full-blown sleep apnea. And so sometimes you'll get the report back, everything's fine. Even though with my kids' sleep apnea testing, it came back with my son 300 and something episodes of snoring through the night. Yet I was told everything's fine. And I'm seeing signs of wear, I'm seeing all these sleep apnea or the sleep disordered breathing issues. So hence why I'm very passionate about all of this. I see it in myself, but also in my family. And so it's good to see somebody who is very aware of pediatric airway concerns. Most professionals are not looking at all the things I just showed you. Most dentists are not looking at all those things. Most doctors are not looking at all those things. The problem has been that these issues overlap a lot of what a lot of professionals are doing. And so no one's really, I guess, looked at the whole big picture of it. And no one's really taken accountability for it. There's not really been a profession devoted to all of these issues before. So the dentist looks at the teeth, the doctor looks at the health, the ear, nose, throat specialist looks at the ear, nose, and throat, the chiropractor looks at the posture, the temporomandibular joint specialist looks at the jaw, schools and other therapists work with behavior and learning issues, the massage therapist looks at the tension issues, speech-language pathologists look at speech, hygienists look at the health of the gums and the bone, and yet this spans all of those and more. And so it's really been kind of neglected. And unfortunately, in any kind of university program, we're not taught this stuff either. And so I happened to stumble upon it. But there are a lot more professionals who are starting to come across it and realize that, yeah, this makes sense. And when they start to learn about it, they actually start seeing it in their patients and they go, yeah, this is connecting all the dots. Or they oftentimes, a lot of professionals will refer to it as it's putting all the puzzle pieces together. I like to compare it to when there's a whole bunch of adults at a family gathering and there's a whole bunch of kids and everyone just kind of assumes that everyone else is taking care of, your child or whatever, and then all of a sudden a child is lost and everyone says, well, I thought you were taking care of that. And so orofacial myologists are kind of the ones who kind of try and put it all together, and we make referrals when needed, and we're trying to put all of that together. Another analogy that I liked was the blind men who are trying to describe the elephant. So everyone has their own little part, but no one's looking at the full picture. And so as professionals, we need to make sure we're looking at the elephant and not just the one part. All right, so your child needs more than just straight teeth. They need a lot more to go into better development and health. So some strategies to help. Congestion. Make sure you're not using congestion medication on little kids. I remember several years back hearing a news report that came out, and there was a child who had died because they had had an overdose of cough medication, and it is oftentimes because their bodies don't metabolize it, and so it just keeps circulating through, and if they're given more and more and more, eventually they get an overdose. For blocked nose, there's a bunch of different ways. I think I'm kind of running short on time, so I'll just kind of quickly go through. I'll probably just skip a bunch of stuff, but this stuff is here for reference as well with the video. The most common thing babies choke on is mucus. So make sure you have some type of a device to get it out of there. Either the little bulb, or there's other ones where you can actually suck it right out. And it's usually at the back of the throat. So open up their mouth and get right in there. Tummy time is so important. Another one is guppy pose, which goes along with tummy time, but this one's really good at relaxing the throat, tongue, and the jaw. And it's also really good if a baby's had a tongue tie release. This is great to do with them. Getting rid of the sippy cup. So here's a good sequence working towards open cup drinking. Open cup drinking is the very best. That's what you want your aim to be. And you can see even down here, they have little cups that have a cutout for their nose to make it easy. So those might be good beginner ones to start with. If you really feel like you have to have a sippy cup, the 360 cup is, I guess, the lesser of the evils. It tends to not promote such bad swallowing habits, and it doesn't spill. So, but it shouldn't be used past 18 months. This book is fantastic. It goes through all sorts of stuff with helping your baby on all the stuff that I'm talking about. Diane Barr also does orofacial myology, so she knows all of this information. If you need a frenectomy, get one. Again, it makes a huge difference. If you're having the symptoms or function is being compromised, it's better to just get it done. It's good to start early. So this is one that I'll probably skip through the rest really quick, but this is one that I wanted to talk about. So George Catlin was a lawyer, artist, and later in life he was an author during the 1800s. He was very interested with the Native Americans from various tribes. Catlin noticed a remarkable difference between infant mortality, overall health, and improved facial appearance in the Native Americans versus populations who had their influence from the European nations. Between 1830 and 1860, Catlin visited more than 150 Native American tribes in North, Central, and South America. In total, these tribes had more than 2 million members. His first observation difference was their diet. The Native Americans ate mainly wild-caught fish, buffalo meat, venison, maize, and vegetables. But as he kind of went and visited all these people over 30 years, his final conclusion to their good health was the fact that they encouraged nasal breathing day and night right from birth. So he ended up writing a book called Shut Your Mouth, Save Your Life. And he said in the thousands of women he had observed in their Native American tribes, he never once saw a mother withdraw the nipple from the mouth of their baby without carefully closing its lips with her fingers. He said, I was soon made to understand, both by their women and their medicine men, that this was done to ensure their good looks and prolong their life. So shut your baby's mouth. After you finish feeding them, just kind of bring the jaw up forward and close it up. It also helps to elevate the tongue and get that tongue to palate posture starting. But important, if they are continually opening up their mouth, or you notice that there's any Like if they seem to have any type of congestion, or it's even good before you're doing that to check, feel how much air is going through their nose. If they're having any issues, do not be closing your baby's mouth, because we don't want to be causing any type of airway problems. So the big three: lips together, breathe through your nose all the time, tongue to palate. Orofacial myology, myofunctional therapy, it's all kind of the same thing. We work on all those things, and if necessary, refer for speech therapy afterwards. So here's some examples of myofunctional therapy. I don't like to usually show photos, because I know when I was first getting into it and people showed photos, I thought, it just looks like someone's closed their mouth. And so like when I would look at the first picture and the last picture, I'm like, they just closed their mouth. Like, what's the big deal? But if you look at the first picture, that's how that person was all the time. Like when they were sitting, watching a movie, that's what they looked like all the time. And in the last picture, now that's what they look like all the time. You can see their eyes are even more alert. They have more definition in their cheekbones, and their jawline is more well defined. Here's another one, same kind of things. This client had already gone through braces. Everything was looking good, but after braces, his bite opened up because of his tongue. So I have a patient right now who has gone through braces twice. Each time, bite has opened up due to the tongue. And she's going to go back after we're done myofunctional therapy and go get braces one more time. But it will be for good this time, because we're fixing all the functional problems. So unexpected results. Some people, this was a colleague of mine. She had one client whose eye was turned off to the side. And as they began doing myofunctional therapy and he had his tongue tie release, she said each picture that she took through the therapy, his eye kept getting straighter and straighter, and by the end, it was straight. Also, there's links with trichotillomania. So there have been patients so trichotillomania is someone who has an urge to pull their hair out, basically, or their eyebrows out. And there have been patients who have gone through myofunctional therapy, and when they finish therapy, their trichotillomania has either decreased or it's completely gone. And so I feel like this is an area that needs so much more research. There's links to so many things. So there's different appliances you can start with kids when they're little to help growth. Traditional orthodontics, retract. We want to make sure we're bringing forward. And so this is something, this person used expansion appliance called, or it's kind of a system called orthotropics. And you can see the difference. Everything, their jaws have been brought forward rather than trying to retrude. And so not only does she have better airway now, she has better health because of that, but better aesthetics as well. So I think a lot of the time we look at beautiful people and we think, oh, they're so great because they have, nice cheekbones or whatever. But I think underlying all that is that they have great health. And so that's what we want. And my very last slide is good brain development. So not only do we want good oral development, we want our children to grow with their brains. So Dr. Robin Gibb is here, and I attended one of her presentations, and so I've included some of her links. But some of the stuff that I mainly got out of her presentation was, it's so important with kids to have back and forth. Taking turns or talking to your children, asking questions is so important. She talks a lot about the effects of toxic stress on babies and children and how that can affect their health even into adult years. Children learn best when learning is fun. So don't use flashcards, make it a game. So I have some of her links there. Then there was a presentation done by an SLP here in Lethbridge, and hers was entitled Electronics and Brain Development. And so my big takeaways from hers was research shows that babies and young kids do not learn through a screen, even the educational programs or the apps you get. And they don't really learn at all. And in fact, some research shows it's actually worse for your kids. They need human interaction. And so I put a link to that video, so if you want to check that out. And then the very last thing before I close was, I love research. And so when I had my first child, I got out books from the library all about brain development with kids. And so one of the ones that I actually tried on my oldest child that worked was that they had done a study where they had taken a group of parents who were going to be having kids soon, and they had told them to read to their children every day right from birth, but to also, in addition to reading to their kids, ask questions the whole way through the book, constantly be asking questions. So at the beginning of the book, what do you think is going to happen in this book? And even though the baby is brand new, you give a pause, and then you can answer, or you ask another question. And so they encourage this type of reading with their children. And then the other group, with parents who are about to have kids, they encourage them to just read to their kids every day, but they didn't give that extra instruction for asking questions. So then when these kids got into school, they assessed them. The kids who had the parents who were asking them questions blew my mind, but the results were that their reading comprehension levels were 6 grade levels above the ones who had been read to every day. And so I was like, whoa. So I did that with my oldest daughter, and we read a lot, and I asked a lot of questions. And when she got into grade 6 and had her PAT, she had the highest mark in her school for reading comprehension. I didn't do it as good with my other kids because I think I was just more busy, but we did a lot. I did a lot with my oldest, and she is an avid reader, fastest reader I know. When we went to parent-teacher interviews, they said, how do you learn? She says, I learn by reading. That's my best strategy for learning. So that's a great thing to do with your kids, is always asking questions. And that is the end.